This is my kickoff recording for ANS Pharmacology. And of course, as an introductory video, we should know about fundamentals, things to review, which we assume you have already discussed in your prior fundamental prerequisite physiology classes, right? It would be obviously very difficult to proceed with the drugs without knowing an idea about the system that we are trying to understand and treat. Okay. And this is further complicated by the fact that the nervous system is much more complicated than just the autonomic, right? Because the nervous system can first be divided into two, the central and the peripheral. The central, of course, has the brain and the spinal cord, and the peripheral portion contains all the other parts of the nervous system, the nerves extending to all other parts of the body. Now, the peripheral nervous system can be further divided into the somatic and autonomic, wherein a major factor dividing these two is voluntariness, wherein the somatic contains portions that you are supposed to control, especially muscle motion. Like you can dictate whether you want to move your hands or not, you want to, walk or not, you want to move your face or not. The autonomic nervous system contains control over organs which are supposed to function without you controlling them or needing to control them. Like the heart is supposed to beat. It's not like you tell your heart, stop beating. It will not stop despite that. For example, urination, though you can try to stop it, but there will be times wherein it's uncontrollable. So is sweating. So is outflow of tears. So is your tummy really moving and causing diarrhea. So those are the automatic or autonomic things, which are the focus of the drugs that we will be covering for this playlist. Now, it would be a wise idea to just have a brief, very simplistic way of reviewing the anatomy of this one. And just to contrast it with the somatic, I have made this one. Nothing probably simpler than circles and dots and lines, right? So we can represent the somatic nervous system as having an organization wherein if I start at the CNS, and this is part of the spinal cord, and there's a signal, an impulse, or a synapse that travels from left going to the right until it reaches an effector organ, which is, well, the effector organ for this one, for example, are our muscles. Then the direction is straightforward and the motion is just almost one movement. Whereas in the autonomic nervous system, there is a marked presence of structures in the middle called the ganglion. Thus, from the CNS going to the effector, we have some kind of, middleman. And therefore, it's as if our nerve fiber from here to here is divided into two halves. Not really half, because many times this is not equally long as this, but two parts, basically. First, the part between the CNS portion and the ganglion, and then the part between the ganglion and the endpoint, which is the effector. So we have terms called preganglion and postganglion. Now, of course, since we're talking about these being the road where the synapse will travel, we can also call this fiber the presynaptic. And then this one, because this is the second half that, or the second part that the synapse travels, the postganglion or the postganglionic. Sorry, I already wrote ganglion here. So postsynaptic, I mean, postsynaptic fiber. So sometimes the terms are used here, sometimes it's here, but these are for most part synonymous. Presynaptic, postganglionic, postsynaptic, postganglionic. Okay. And of course, if you really did a comprehensive, or not even comprehensive, even a complete but short discussion of ANS before, you should know that there are two divisions, the sympathetic and the parasympathetic. Something like, it's usually described this way, right? Sympathetic is what they call fight or flight, right? Because they say this one activates more on times you need to do intense activity, whereas parasympathetic is called the rest and digest, because it's the one that's dominating if you're not doing a lot. And of course, this classic table should be something that anyone who did study these would remember, right? And here are organs under autonomic control, the eyes, a lot of our glands, the glands that take care of the HCl in the stomach, sweat, salivary glands, the glands in our eyes that control the release of tears, bronchioles, and all the way down. And just to briefly go through them, let's just read them a bit. Of course, not expecting something like fundamental back to square one anatomy physiology discussion, let's go make it short. Eyes. Sympathetic causes mydriasis, which is another term for the widening of the pupil, whereas for parasympathetic activation, meiosis, which is the narrowing of the pupil. So like widening, narrowing, opposites, right? For HCl, sweat, saliva, and tears, all of those secretions go down in sympathetic activation. All of those go up in parasympathetic. Bronchioles dilate under sympathetic control, constrict under parasympathetic. Heart rate and contractility both increase in sympathetic and both decrease in parasympathetic control. Okay, just in case in the future we encounter these terms, we have technical words for these. For heart rate, a commonly used word is chronotropy, having to do with, chronos, a prefix of time, and rate is speed, which is related to time also. So there's the relation. And then contraction, contractility, how strong the heart beats. A word for that is inotropy. So sometimes you might hear the words positive chronotropy or positive inotropy. Those just means increase in either of those. Or negative chronotropy, negative inotropy, the decrease in those. Okay? For blood vessels, they constrict under sympathetic and dilate under parasympathetic control. And this is very important because both these functions, positive, chrono, inotropic effects, vasoconstriction, increase blood pressure. Whereas, of course, the reverse of that would decrease blood pressure. So you should expect there are drugs in ANS pharmacology that are dealing with hypertension or other things that affect the heart or blood pressure. But motility goes down in sympathetic, goes up in parasympathetic. Bladder relaxes in sympathetic and contracts in parasympathetic. And that means that if it relaxes, it's not going to force urine to go out. If it contracts, it causes urine to go out. So basically, this means that you are promoting the process of urination, or another technical word for that is micturition. Okay. And then even the uterus is affected. It relaxes under sympathetic control and contracts under parasympathetic control. So you can probably imagine a lot of drugs here which affect many different patients, those with problems in their cardiovascular system, respiratory like asthma, even pregnant patients, even those who have a hard time in their genitourinary or gastrointestinal. So that just explains why there are a lot of drugs to be faced in the future, but that will be for the future, because one of the essentials that we do need to discuss right now also is what are our ligands that trigger these effects. Of course, we need to deal with our neurotransmitters. Particularly, there are two major ones, acetylcholine and the catecholamines. Take note, it's plural because there are three catecholamines. Dopamine, abbreviated as DA, epinephrine, abbreviated as E or sometimes EPI, and then norepinephrine as NE or NEPI. But personally, I prefer just using the shorter ones. And also, a little bit of history would remind us that epinephrine is also equivalent to adrenaline. That's the other name. And of course, norepinephrine is noradrenaline. Why is this important? Of course, we're talking about pharmacology. We're talking eventually later about receptors being targeted by certain molecules and causing activation and agonist. And of course, we recognize that neurotransmitters are the original agonists that cause these effects. So we should pay respect to them because they are what we model our drugs after. And more importantly, do you know that depending on what division and what part of the fiber we are in, the neurotransmitter may change? Though not so much, because here I already made the tabulation. For most part, acetylcholine is the dominant ligand. And catecholamines only come at one time, and that is when making contact to the postganglionic area of the sympathetic division. However, in that case, we can now establish one thing. It's that the catecholamines, which is represented for the namesake later by adrenaline, are the ones that really tell sympathetic their classic effects or control how they work. So sometimes the sympathetic division is given the other name adrenergic division or the adrenergic system even because it takes after adrenaline. Whereas in parasympathetic, because across the board, preganglionic and postganglionic, it's nothing but purely acetylcholine, then we grant it the other name cholinergic. And of course, For the rest of the ANS playlist, we will be dividing it into two parts. The drugs covering the adrenergic division and the drugs covering the cholinergic division.